Hello, I'm Tony DeMaria, the editor of JACC, here with the highlights of the August 14th issue. The first paper I'd like to tell you about deals with the value of the QRS morphology on ECG as well as the duration of the QRS as it relates to the outcome of cardiac resynchronization therapy. Now, we all know that CRT is ineffective in about a third of patients, and so it's very important for us to have the ability to identify those patients in whom it's likely to be most effective so that we don't waste this therapy. To this end, the group from a Cleveland clinic examined nearly 500 patients who underwent cardiac resynchronization therapy and divided them into 4 groups based upon the presence or absence of left bundle branch block and the presence or absence of a QRS duration of 150 milliseconds or greater. And what they found was probably not unexpected, that echocardiographic ejection fraction improved the most in those patients who had both left bundle branch block and a duration of 150 milliseconds, and there was a progressive decline to the group, the 4th group, that had neither left bundle branch block nor QRS duration of 150 milliseconds. And in fact, the difference here between the best group was a 12% increase in ejection fraction versus only a 3%. Now, there was a similar trend for death, but this wasn't significant. Of course, these data are limited by being single center and retrospective, and they're probably not sufficient at this point to change guidelines. For all of us clinicians, however, they may be very useful data in identifying whether or not to employ cardiac resynchronization in those borderline patients. One of the interesting papers in this issue of JACC deals with trends in hypertension prevalence, awareness, management, and control from NHANES. You'll recall NHANES is the National Health and Nutrition Examination Survey, a very important and well-done survey of national trends in health and nutrition. And in fact, early NHANES surveys showed a significant improvement in hypertension in virtually all regards. However, importantly, the last report, which extended to year 2000, showed an increase in the prevalence of hypertension without any change in management. So now this latest report, which deals with trends in hypertension from year 2000 to 2009, is very, very important. And in this most recent period, the prevalence of hypertension was stable, but awareness and control did improve. Now, in fact, systolic blood pressure decreased 4 millimeters and diastolic blood pressure decreased 3 millimeters, pretty good. However, the overall prevalence of hypertension remained at 30%, nearly 1 out of 3 Americans. Nevertheless, even though we have the improvement with overall blood pressure, the overall rates of improvement were relatively poor. Only 74% of hypertensives were aware of their disease, only 71% were under management, and only 46.5% of hypertension had their hypertension adequately controlled to goal. So important messages for us. We seem to have plateaued a bit in our efficacy in diagnosing and treating hypertension, and this should be a wake-up call to the medical and cardiovascular community that we need to improve and enhance our efforts at treating patients with hypertension. One of the issues all of us are grappling with in this day and age is that of rehospitalization of patients, particularly with heart failure, but also of acute myocardial infarction. And a paper that we have in this issue of JACC deals with that very issue. And it was a survey of hospitals that are enrolled in the Hospital to Home program of the American College of Cardiology and the Institute for Healthcare Improvement. And there's nearly 600 hospitals that are involved in this program in some shape, manner, or form, and they were surveyed as to what their policies were in terms of trying to prevent early rehospitalization of heart failure and MI patients. And the bottom line of the survey was that although about 90% of hospitals indicated that they had some written policy to deal with this issue, the nature of their policies differed a great deal. And in fact, in terms of 10 potential actions that could be taken, the average number of actions taken by any individual hospital was only about 4. So these data represent an interesting spotlight on the status of hospital and physician responses to this issue of rehospitalization in this day and age. It shows that there's still considerable fragmentation and still a lack of universal agreement as to how to minimize this problem. Thanks for watching. For Inside JACC, I'm Tony DeMaria.